I'd like to now welcome and introduce our main panelist, Dr. Andrea Ruth, who is the physician leading Santa Barbara Neighborhood Clinic's efforts to screen for ACEs in all of their pediatric clinics. That's Dr. Ruth. Lori Goodman, the executive director of the Ella Vista Youth Project. And last but not least, our moderator for this evening, John Clark. John is the president of the James Bauer Foundation, who I would like to add has been incredibly influential in not only funding but also advancing ACEs as a key initiative in our community.
My job is to moderate, and so for the most part I should try to talk very little. But I did want to, and we talked about this before, as one funder that has been working in this area for a while, share some lessons from our pathway as a funder in this area to you as another funder that's working in this space as well. So I'm going to do that for a couple of minutes, and then we'll get into the main part of the conversation. So just as a start for the Bauer Foundation, this has become a tremendous area of focus over the last few years, and we didn't expect that. We didn't come into this space or come into this work as sort of a clear intention when we really got started a decade ago. We came back to this as work because we just kept seeing it everywhere. You know, we just kept seeing the impact of childhood trauma in the other outcomes we were funding for. So it's pretty easy to go to a place like Storyteller and see, wow, this is childhood trauma. This is what this looks like. Here is a preschool set up to respond to childhood trauma. But you also, when you're looking at place-based work and school readiness and talk to preschool teachers, you hear it. We have these kids, they're like this. You know, we have difficulty getting to this because we can't manage my classroom. You see it when you go to Los Prietos Boys Camp. You see it. When you meet kids, young men and women that are gang involved, you see it. So everywhere we looked, we were seeing this as an issue that was sort of embedded and underneath so many of the goals we cared about. And really, when you take a step back and think about Elena's presentation and add in sort of that idea of epigenetics, the way that these experiences can be passed along as our DNA is read, and you think about our country and our community's history of trying to create pathways of social mobility, and you wonder why they haven't worked. Well, that's because a lot of this interaction between family ACEs and neighborhood stress and trauma and racism and that epigenetics like digs these problems in, so that we really do have to respond in a really comprehensive way. So for our foundation, we've been looking at this for a while and trying to figure out what might be the role of private capital in making a difference. And we really have come to, we've been thinking about things, and we had Laura Porter was here a couple of weeks ago for a conference, and she just was able to say what like my feeble mind was trying to like focus on and get to, and I just want to share that a little bit. So as Elena was talking about, ACEs is not a diagnosis. You know, it is an assessment of risk, and it really is part of our evolutionary natural response to danger. You know, this system was built in us to be purposeful, and the challenge becomes when particularly children, as Elena said, have this response, and then they go interact with the rest of the world. That interaction sometimes doesn't work well. So for example, if you have a child with high ACEs and they're in a preschool and they can't self-regulate and they're acting out, and the teacher comes in with, you know, a normal rational response to that, like if you do the right thing, I support you. If you do the wrong thing, I maybe separate you from the group, or I punish you in some way, which may work for other children. That may absolutely not work for that kid. In fact, it may actually trigger more trauma and make that whole situation worse. And when that happens time and time and again, and that kid gets kicked out at the age of 3.5, that interaction again is taking the trauma response that the child is bringing into the situation and just making it worse. And so if you look at the way we interact with children, particularly in our systems like healthcare, like criminal justice and education, we have all these places where a child's response is being responded to by the system, and that response moment we can even either make it healing or better, or we can make it worse. And so for us as a foundation, where you look through all the places where we have sort of child-facing moments, and to say, where can we make that interaction better? And where can we make that interaction better on a consistent year-on and year-on basis? So for us, that's a focus, and you will definitely hear that later tonight. And I would say towards that, and this is funder speak, and I'm really sorry, but when we think about our grant making, so often we think about it in the way it was described today. You fund a project. It has a beginning, it has an end. There are outcomes you are looking for. And that is totally important, but completely inadequate to change an issue like this. Because beyond specific projects, there are two things that I think as funders we absolutely have to look at. And one is systems, and Elena talked about that. And that's one of those fuzzy philanthro speak things, systems change, like what does that mean? But you really have to understand that. So to start with, we all have systems. I have a system. It's my defaults, right? It's my habits. It's like I tend to get up at this time. I tend to exercise in the morning. I tend to eat these kinds of foods. And I know the older I get, now I know you guys aren't that old, but the older I get, the more I realize my habits drive my outcomes. And so if someone was coming to me and say, hey, I want to improve your fitness, they might give me a program, but what they'd really try to do is change my habits. Maybe not so many fig Newtons, right? Maybe a little more strength work, something like that. They're really trying to change our habits. All these systems that we have, education and healthcare, they have systems built in them, the day-to-day way they do work. And those systems absolutely drive the results. Have you ever tried to fund something in the school system? Who has tried to do that? Has anyone tried to do that? Tough sledding, because the schools have a way. They have a way they manage their classroom. They have the way they manage the districts. And if you can't fit your intervention into their workflow, you're done. Same with healthcare. Healthcare has a system and a way they do their work every single day. You'd be amazed how much in healthcare the system is driven by the drop-down menu on the patient screen. So you have to be looking past these interventions and looking at the way these systems work every single day. One more example. No, wait, that's for the next one. So system is one. The other thing that's super important is culture. Peter Drucker said, I always mess this up, culture eats strategy for lunch. It could have been breakfast. I don't remember. But organizational culture and family culture drives change everywhere. So for an example, we've been funding work in advanced care planning in this community, and most of the advanced care planning work is done by people like me, for people like me. And it's no surprise when that doesn't really work very well in the Latino community that has an entirely different set of cultural norms about how do you treat people at the end of life. And so it's not just translating the material in Spanish, it's understanding, well, how do you view this? What do you value? What's important to you? And starting that whole process over, taking that into a place. Organizations have culture too. Now, Elena is going to talk more about the mental health consultation model. That started between Calm and Storyteller, and the reason it worked, and the reason this partnership has worked, is that their organizational cultures are really similar. When mental health consultation first went into the school district, it was a rough couple of years. Not because everyone didn't want it, but because the cultures of those organizations were so different. So you're really looking at driving change, and private capital can do this into systems and into culture. So you're going to hear more about that in just a little bit. So I got on this bandwagon because of Lori a number of years ago, who sent me the TED Talk from Nadine Burke-Harris. So she said, you should watch this, and I sat down and I watched it 3 times in a row. I was just blown away. And it's not because I didn't know the science. I had heard Dr. Folletti speak. I had read it. They had this really funky website that you could get the whole report and download all the data. But she was able to articulate this issue in a super clear way. And to me, what she said is, I represent medicine, I'm a pediatrician, and now I care about this. Because this issue had been in the early childhood space forever, kind of getting nowhere. So when you have healthcare come and say, we're interested, you know you have a game changer. Plus, as I hope we'll be able to talk about soon, you have a consistent way to meet families very early in the life of a child and get to know them and get to support them, which we did not have before. So it was an absolute game changer. We started to get people around the office at the Bauer Foundation. We pulled in Michelle to help us make progress. We talked to Deborah Holmes and Terry Allison. It's like, can we do this here? Can we do this here? We met Sarah Hemmer, who knew Nadine Burke-Harris and Ed McKinley, and all of a sudden we were in San Francisco. It was awesome. I got to sit next to Nadine Burke-Harris. She was right there over lunch. Like, she's charismatic. But we started that process. we talked with Chuck and Nancy at the neighborhood clinics, and we were moving along, and at one point, Nancy said, stop, we got to bring in Dr. Ruth. And so that was a game changer for us. Dr. Ruth came into the effort, we got focused, we got speed, and pretty soon this partnership was arranged. So first question is going to be for Dr. Ruth. And so this is really sad, by the way. I printed this out in 16-point font with the hope I could read it without my glasses. So give me a second.
I have 15 points.
Yeah, 15 point. Well, you're like way younger than I am. So here we go. Next time, 20 point. That's just the way it is. Just gotta say. So, Andrea, as a pediatrician at the neighborhood clinics, you're a lead in this effort. Could you tell us more about the project, and I guess maybe start with what you see in families that has compelled you to do this work, how things have evolved, what some of your challenges have been, and then maybe talk a little bit about where it's going.
Great. And thank you. And again, I do want to thank the Women's Fund for the support of Santa Barbara neighborhood clinics through the years. By supporting different aspects of our mission, it helps us to provide this whole person care that we're providing with medical care and mental health care and dental care. So thank you for all being here. When I first, many pediatricians, when we're first asked, do you want to screen for ASIS? The first reaction is, oh no, I don't know, because I know these families are having these adversities, but what am I going to do when I screen and find out? Or I already know, I think I know what they're going through. Why screen if I don't have something that I can do? So we are very lucky to live in this community of Santa Barbara where there are a lot of creative, talented people, including all the people in this room who want to think about issues. And so this effort had been going on before I joined. Different sectors of the community, healthcare, education, childcare, child welfare, the hospitals, the public health department, and they were talking about what to do about adverse childhood experiences. And we were able to actually think about what could we do, what could we put in place. And so we were able to develop this partnership with CALM, the neighborhood clinics, and UC Santa Barbara. And we were very fortunate in this community to be able to have that university connection. And we met and we met and we met and we thought, well, what are we going to do about childhood adversity? Recognizing what Elena said, it's not destiny, and when you're a pediatrician and you learn here's something that's going to affect health across the lifetime, you want to prevent that exposure. That's number one. Number two, you want to screen for that exposure. And then if children have been exposed, you want to treat the symptoms. You want to give them skills to be able to deal with those symptoms. And then you want to educate parents. So we were able to, think. It took a long time to decide. The science is still developing. I wish I could say, if you have ASIS, you need to do this, and then, then you will know that you will have a great outcome. We listed the things with Elena, but we're still learning. So we designed the Santa Barbara Resiliency Project, and we decided, we want to take a preventative approach. We want to start with infants and their parents, and we started screening infants and their parents starting at a 4-month well-child visit, and we decided we're going to study this rigorously with outcomes, which was, again, in the world of healthcare, it was great to be able to have a partner in UCSB. So if this is the right slide. Okay. So again, the idea is that parents are going to their pediatrician very often in infancy. So we know each other, we trust each other. Parents are poised, they're ready to learn about all kinds of things, car seats and, starting solid food. So it's an appropriate time to be teaching them about things, and that parents are anxious to learn. And so our study is basically we screen the children and screen the parents for the parents' ACEs, and we ask about their child ACEs. And that actual questionnaire, the parent ACEs, is in your program. I know it's dark, you can't see it now, but if you want to look at it later, that's the actual questionnaire that we use. And then we decided if the infant had one or more ACE at that point at 4 months of age, or the parent had 2 or more, that we would offer them the opportunity to participate in this study. So, and that we're trying to see what is helpful. So one aspect is we have what we call wellness navigators, and they're staff members that come from the community. They're bilingual, they're bicultural, like the family advocates being funded at IVYP. They connect families to resources, and the most common resources in our community in the medical clinic are medical health insurance first, but after that it's housing, food, and quality childcare. Those are the things that people are looking for. That's one group, and people are randomized to different groups. The next group gets the Wellness Navigator and the opportunity to meet with a parenting specialist at the next 4 well child visits. And during this time, they're taught some of what Elena taught you tonight about brain development, about toxic stress and its effect on children, about resiliency, about how to read the cues from your infant, about how to play with your infant. And then the third group has those 4 lessons at the well child and 4 home visits. People are assigned randomly to one of those 3 groups, and then at the end of, it's about a year to go through the study, we're studying a variety of outcomes. I'm not going to list them all, but the categories are the health outcomes and the medical outcomes that you would be interested in. The parenting outcomes. How stressed does the parent feel? How effective do they feel like they're being as a parent? How supported do they feel? And then the infant outcomes, again, health, development, socialization, but also how resilient is that infant. And I will say that we've been doing this project for the last 2 years. Of the parents that we approached, they're coming in for a checkup. 90% of them agreed to participate in this clinical study, which to me was just remarkable. It was a surprise, but an indication of how needed this intervention is. And we have over 100 families in the study, and we're looking forward, and probably in about another year, we will have everybody through the study and we'll be able to report the results. But we've had a lot of lessons that we have learned as a result. The first thing is parents appreciate being asked, and they do understand how this pertains to their child's health. One of the first families that I gave the screener to, she marked her ACE score as 10, which meant she had all of the childhood adversities. She has 6 children. When she handed me the screener back, she said, Dr. Ruth, I actually feel good handing this to you because that was my childhood, but I am a different person than that childhood, and I want to do better for my children. I want to learn. I want to help them have a good outcome. So, I feel good. And again, that was eye-opening for me, but an important lesson. When you start talking to a parent about if you had a stressful childhood, if you felt that you had some of these difficult experiences, it might affect how you respond to the stress of being a parent, and when you start talking about that, they'll start to nod and they'll say, we have some things that we'd like to offer that might be helpful. The families are anxious. They want to learn, both mothers and fathers. They say, I didn't have the opportunity to learn these things. I would really like to learn these things. The next thing we learned is it's important for organizations that deal with children and families to learn this, just because of what John said. We need to be able to understand how to respond to families so that we're supportive, so that we help them to feel better by what we're doing instead of feeling worse. And our staff, they have loved the training that Calm has provided for us. They feel like it helps them understand. Sometimes when they feel like they're having a reaction to a patient who maybe is having a hard time, all of a sudden it changes the perspective to one of empathy. The next thing is it's important that all levels of the organization are involved. So I'm very fortunate to have Nancy Tilly, our COO, and Dr. Fenzi, our CFO here. They have been involved as partners on this project from the very beginning. So it's really important when you're talking about a culture change that you think about all levels. The last thing is that, and this was not something I anticipated, when you teach parents about this, first of all, again, it makes sense to them. And all of a sudden, they feel empowered to do something for their children to try to prevent those effects of the adversity. Because now they have a reason. They understand, okay, I can do this. My child can have a different experience. So one of the families in our program, her husband was deported partway through the project, and she has no family here. She's socially pretty isolated. The next day, she came into the clinic, met with the Wellness Navigator, and she said, I need to go back to work. I need some help. I need to find some quality childcare. I need help with various things. I want to make sure that my children are not affected by this experience. And sometimes families don't feel empowered to ask for help. So I think rather than, again, being a labeling or a negative experience, it can be a positive experience because it gives parents something that they are able to do to help their child. So I think I'll stop there.
So, as one follow-up question, so there are now 2 clinics that are doing ACEs screening response, and then there's PERC. Do you want to talk a little bit about PERC, and then we'll talk a little bit about PERC.
Thank you. So again, we're really fortunate in Santa Barbara to be part of a community that is interested in making change. So our clinic began our project first, and then Carpinteria Public Health Department with CALM, a very similar project. But now we're fortunate to have some seed funding from Cottage Health to begin to help other clinics implement this same type of screening. So PERC, it stands for the Pediatric Resiliency Collaborative. This is our vision, building healthier families and communities. I'm going to go to the next slide. Let's see. Whoops, did I go too far? There we go. Okay. We're basically starting to support other pediatric clinics in this same process. So we want to educate providers so that they feel comfortable doing the screening. We want to put services in place for families that have been exposed to adversity. We want to improve the communication between all of the organizations that serve children and families. And then we want to ultimately build resilience in children and families in Santa Barbara. So we have an ambitious plan, but we have 4 clinics enrolled for the coming year, and we're going to enroll 4 clinics for the next 2 years so that we can screen all children in Santa Barbara County for exposure to ACEs, and then, more importantly than just the screening, provide factors to promote the resilience in these families.
Thank you. And so, as you've mentioned, this has been a partnership between your organizations. So do you have 1 or 2 between the 2 of you, like brief learnings of this is what we learned about each other or working together, any sort of nuggets of wisdom gleaned from your partnership?
You need a pediatrician champion, and you couldn't ask for a better pediatrician champion. So I would just kudos to you because you have been like the guiding light for this. And the fact that we're in 2 clinics, we're going to be in 6 clinics at the end of 2020 and 10 clinics by the end of 2021. Each of those clinics has their own respective Dr. Ruth. I mean, Dr. Ruth is herself, but there's a pediatrician champion. So I think that's really important. So I just want to give you that shout out because you really single-handedly have shifted this. But I think the lesson learned, I mean, going back to your culture comment, it's really groundbreaking to have social workers or marriage and family therapists working side by side with physicians. That doesn't typically happen. Those aren't professions that necessarily rub elbows all the time or have an easy way of getting along. There are perceived structures in place of who has more say. But what I think has happened is that there's a respect for each culture and a respect for what a physician can bring. Because these families, the reason I believe change is possible is they have this little bundle of joy at the 4-month well baby visit, and they want to do everything in their power to be the best possible parent. And the pediatrician is this trusted advisor who, whatever the doctor says, you do it. And so, but having a physician and the entire clinic trained in understanding trauma-informed care and trauma-responsive care to look at that family, again, like I said earlier, not what's wrong with you, but what happened to you, and then recognizing with open arms that the social worker or the marriage family therapist could add value and could broaden the support all together in one place. It's that understanding of culture, and it's a shift in the systemic delivery of service. So what is exciting to me is the shift in pediatric care. It's going to just be done differently. It's not like we're adding in a program. It's transforming the delivery of care. And for me, that's powerful.
And just to add, so bringing CALM into the medical clinic, it really enhances the quality of care of what I'm able to provide to the family. It's almost as if there are now 2 people that they get to speak to as part of their well child visit. There were a lot of bumps along the way. People have their turf. What do you mean this family has to wait to see the therapist when I really need to get moving on to my next patient, and what do you mean we have to schedule 2 visits at the same time? So you have to be willing to, sort of ride it out and remain calm. But again, I think hopefully you're catching a vision. This is groundbreaking. This is revolutionary, and we need to actually be thinking differently about how we care for families in our community. And it's been nothing but positive as far as the results.
Great.
Being able to have expertise.
Thank you. So Elena, in addition to partnerships with the neighborhood clinics and other providers, folks in Carpinteria, COM has really reached out, and I was about to say you guys are everywhere, but that's creepy. But you're in a lot of places that you weren't 5 or 10 years ago. And one of the big vehicles for that is the mental health consultation model, which as you know, I think is an absolutely horrible name. But anyway, it is in a bunch of places. It did start at Storyteller. It moved into the preschool system, and now is in every primary school in the Santa Barbara Unified School District, and there are almost too many other districts in this county that want that program. So could you talk a little bit about the evolution of this and what it means for COM and what the kind of core part of that work is in the school system?
That's a lot. So I would just say it started with one child. It started with one child, one preschool teacher, and one therapist at COM, a child who was in foster care and was at Storyteller and then immediately got removed and taken to a new foster home outside the area, and those teachers that worked with that child were devastated. They had put so much time and energy into supporting that child, and then the child was gone, and they didn't have time to say goodbye or process or anything. And so it really was this organic process of the director at Storyteller reaching out to the director at COM and like, how do we support the teachers? And from that story, this whole model really evolved where the children in the schools or the preschools are obviously the North Star. We want to make sure there are better outcomes for kids and their parents and for families. But the motto really emphasizes that we need to support those adult providers that are supporting those kids. So just like we're leaning in to support the medical providers and the pediatricians that are supporting those children in the school setting, we need to support the teachers and the administrators because that's where you can have more longer lasting change. You can change, just like you can change the practice of a pediatrician's office, if you can change the practice in a classroom or change the practice in a school or an entire district, that's where generational shifts can happen. So it started at Storyteller, it moved into other preschools, and then this is the second year we're in Santa Barbara Unified. Last year was the first year, and that was a big deal to enter into a behemoth school district in a pretty universal way. And it came to be because we had a suicide cluster in Santa Barbara. I don't remember the exact numbers, 63 attempts a few years back, 3 or 4 completions, 4. Third graders attempting. I have twin 4th graders. They are 9. So we're talking about 7 and 8-year-olds. And the district knew that they had a problem. And so they put out an RFP and they wanted to work with a provider to co-create some kind of mental health supports, but they wanted something different. And we were a little crazy, I think, because we offered them something different and has a bad name. It's called mental health consultation. What does that mean? And we have to explain it. But what it means is that we are embedding therapists, they're all trained therapists, as consultants in the schools. And so again, their North Star is the child, the North Star is the student, but they realize that they have to come into that classroom understanding the perspective of the teacher, understanding the perspective of the principal, understanding the behavioral specialist or the yard duty staff or the parent, every single person, because that's who is that support network for that little kiddo. And so you have to work at that adult capacity. Wellness is the foundation for learning. And so just like kids can't learn if they're hungry, kids can't learn if they're worried about the things I mentioned earlier, if mom is going to be home later, or if she's going to be deported, or if dad is going to come home in an alcoholic rage. They can't focus. So they knew that they had to really emphasize this, and they had to prevent suicide clusters. They had to start embedding mental health and social emotional learning And so I don't think calm is everywhere, but calm is where families are. That's what we're trying to do. And we will always serve each and every child or family that walks through the doors of our clinics. But if we can be embedded at IVYP's Child Center, if we can be embedded in the 9 elementary schools, plus 1 charter this year for Santa Barbara Unified, and we're now in Goleta Union, and we're now in Orchid, if we can be growing this and really being where families are, then it becomes part of the systemic fabric of this community rather than just a one-off. But there's a lot of cultural things to navigate. And so this was a big deal because, as John said, there are rules and there are structures and there are habits of school districts. So teachers were very used to therapists coming in and they would say, okay, these 2 children, I'm having trouble. They keep throwing erasers and they keep punching the other kids. And I want you to take those 2 kids, go do individual therapy with them, fix them, and then return them. And we said, it doesn't work like that. It doesn't work like that. We need to actually lean into the classroom. We need to observe what's happening. We need to come in with empathy and a trauma-informed understanding that little 6-year-old in 1st grade might not be comfortable in circle time because his back is to the door. And at home, someone scary comes through the door. And so having your back to the door is triggering. So maybe instead of pulling little Johnny out for therapy, what we need to do is redo circle time. So that it's a very different supportive environment to teach teachers new ways of thinking about things on behalf of the kiddos in their classroom that they hopefully can continue on throughout their whole career. I don't know if I answered your question, but I just talked for a while.
That was awesome. And I think the other part of that I think is, I remember when we took Dr. Cash, previous superintendent, to Storyteller to talk about the model, that other part about reflective practice in terms of looking at the internal experience of the teacher as sort of an actual thing. Like they're responding based on their own history too, and that response is going to impact how they treat that child, and seeing that as an actual part of teaching. When he got that, he actually sat there with super uncomfortable pause, like it felt like an hour, but it was like 30 seconds. And he said, in teaching, we don't do it that way. Our motto is suck it up. That would be transformative. So it was pretty amazing to see that, like, wow, like teachers are people, and they have an internal experience. That matters in terms of how you interact with a child. So Lori, you have a long history with CALM, and now you're heading up IVYP, and you've seen mental health consultation in your own agency and in your district. So maybe you can start by talking a little bit about what do you see and what do you see the promise of that in the area that you work.
Well, I also want to just take a moment to thank the Women's Fund. Your investment helps us be better in everything we do. It's been an interesting shift from CALM, which is a specialist organization and has this special expertise, to move to IVYP, which is a generalist organization, looking at families and the community as a whole. And has been a great pleasure to have CALM as mental health consultants in our child care center, starting really even before preschool, even with infants. That infant room is the toughest room in our center. And the support that our CALM consultants give to those teachers is phenomenal. And it's been incredible to be on the receiving end of reflective practice as a leader, as well as seeing my teachers have that experience. When I think about culture and culture change, we've had this relation, IVYP and CALM has had a relationship, I believe, for 8 years. But the culture of the agency has needed to shift because so many of our staff come with their own trauma history. And we've had structural components of the agency that have exacerbated their trauma history. So part of the work has been identifying what are the structural things in the agency that need to shift so that teachers can be their best selves. What does it mean to be trauma-informed? How do you teach everyone what being trauma-informed is? How does it not just coming from the top? How do we talk about it? How do we develop policies? How do we educate? And how do we build support? And it's starting to feel like a shift, and it's very exciting. And my own experience of reflective practice, which I get from CALM, has helped me be able to navigate that shift. So, I mean, CALM is helpful to so many places in this county in so many ways, and I feel very lucky to be on the receiving end of that partnership.
That's a great answer, and it really points to how deep the work has to go. It's not just a program intervention or a set of strategies. Like you're having to bring it into your culture, and you also through IVYP are bringing it out of your culture, and you are creating the community, looking at the Goleta Valley and bringing people together to talk about ACEs and trauma across a bunch of systems. In your room, you have in the GUSD boardroom, there are sheriffs, there are business people, there are people from the district. Do you want to talk a little bit about that work and sort of taking this up to from an agency level, but to a whole community level?
Yeah. So, John, you talked about systems change. And I think what's so revolutionary about this ACEs work, it really feels like we're at the very beginning of a wave of change that's going to happen. And you see it in the healthcare setting, but it needs to be democratized because every single person, and certainly every single agency, has an ability to make an impact. And so what do we need to do? We need to educate and build awareness so this kind of experience is great. And then we need to build relationships and trust so that people can work outside of their silos. And I don't even like the word silo, but sort of the way they always work. So I have been lucky enough to be part of some visioning process on the county level around ACEs, or now calling it Resilient Santa Barbara. And it started with the idea of building relationships across different sectors. And IVYP, despite its name, really serves the entire Goleta Valley and is aligned with the Goleta Union School District in terms of our services. And in fact, what the Women's Fund funded was an ability for us to hire an additional family advocate to serve more families across the school district. So what I said was, how do we bring this information about ACEs and resilience to my community that I serve? And I looked around and no one else was raising their hand, so I just did it. And I invited everyone I could think of to come to the table to get to know one another. And it shocked me, but people came. The school district, the folks from the city of Goleta, probation, other nonprofits. And the goal at first was just to build relationship, because my theory is just like a child needs a trusted, safe relationship with an adult, agencies need relationships with one another in order to have the courage to try something new and to be different. So we've been working for the last year on building relationships, and I've been weaving in education about ACEs and resilience, and I don't know yet where it's going to go. But I know that even the little bit of relationship building is starting to feel different. People know each other. So I don't know where it's going to be, but I think every community should be trying something, because as you said, the research isn't in yet. We don't know what the magic bullet's going to be. So why not try everything?
Thank you. So one thing we haven't touched upon, and now we're going to move into our last couple of questions, is one of the things that you've seen here is levels of coordination and integration that don't actually exist yet in our community. And so that's horizontal, like how do people that work with, say, incarcerated youth being released, how do they work together to improve those outcomes? And that's usually a bunch of agencies, many of whom don't actually connect very well. And then how do we work vertically over time, supporting families through their various stages of life? So both those things are kind of nascent and in the community. So second to last question, and I think it's only fair since you all have had to sit up on the stage here this whole time. So you're in a group of funders. Wow. And here you are, and you're part of this movement. Like, what are your one or two things that you want to tell the funders? Like, I really want you to think about blank. Come on, this is it. Like, it's in the notes. You know this one's coming. I can't believe everyone's so quiet. It's right here. What do you want them to know? What as a funder, I want you to think about blank.
Well, I'm shameless about
That's it.
talking to funders. The most important thing you can do as a funder is support us to be creative, to take risks. For those of us, and IVYP is an organization that gets a tremendous amount of our funding from government sources. And thank goodness for them, because it's big dollars. But it is not creative. It doesn't allow us to be innovative. It doesn't allow us to make mistakes or take risks. So the more the Women's Fund can think about how to enable agencies to think and work differently and give us that buffer to try new things, that's how we advance the cause. We need to think beyond, we're going to pay for this child to do this. That's how the government thinks. It's not how funders should think. We can do it better. So thank
That's
you
a great
for being
answer.
a partner.
Okay. That's what I was looking for. Great.
Can I add on, or are you moving to the next
It's
question?
not just hers.
Do you want to go in a row? I was just going to say I wholeheartedly agree, and I think just piggybacking your opening comments, I think if we can move beyond funding programs and really funding the relationships and the initiatives, because that's where you move the needle. Because if we just fund X project for 12 months, you make that slice of difference, but it's not changing the habits and the historical context and the long-term relationship. If we're really going to make a difference on childhood trauma, you have to look at who is leaning in together and doing their work differently. So it's the innovation, it's the long-term, it's the collaborative, and it's a way of thinking and a way of being. It's not a program. So I would say that. The other thing I would say is that this county is small enough. I mean, we think we're pretty big, and we are, but we could scale this if we did really interesting things in Goleta, if we did really interesting things in Carpinteria, if we did really interesting things in Lompoc. And then you build up from each of those geographies up into the county, it's scalable. And we're building a pipeline. We're starting in infancy. We're starting in the pediatric space. Before this, the only time a family would be identified as having stressors was when their child showed up to kindergarten at age 5. That's the first time there's any system that could identify what's going on. But by age 5, those brain development is almost all done by age 5. So if that's the first time we as a community can see into a family's life to know that there's a little kid that's suffering in silence, that's a dangerous thing. So if we can start in infancy at 4 months and we can integrate this work into the pediatric visits, and then we can continue on in the preschool space and capture children and families 3 to 5, and then we can move it along into the elementary space and capture kids through age 12, that is remarkable. And we're small enough that we could scale that across this county. So I want to leave you with hope. Like, this is not, like, it is a big issue, but there are ways that we can get our arms around this and make impactful investments that really shift the way things are, shift practice across a geography. So.
And the other hopeful piece, again, this information about average childhood experiences, and when you see those brain scans, those are distressing to look at. But on the positive side, there is evidence that positive interaction with a parent or caregiver builds brain connections in children during that very critical time. So the family is the unit that we need to be focused on, and the parent-child interaction, and all of us and many of you are already thinking in that space, and I think that we can actually do something to change the needle on the trajectory of the life trajectory for these families. I'm excited that we're working on this, so I'm hope that some of you consider being partners with us on this.
That's excellent. Great. Well, we're going to turn things over back to Michelle. I just want to thank you all for listening, so give yourself a hand if you want. Go ahead. Thank you to our panelists for doing such a great job. I guess my only close is just to echo what you said. It's amazing how much has changed in the last 3 or 4 years in this community. When you see cottage health at the table, neighborhood clinics, public health, you see districts at the table, you even see probation and law enforcement at least close to the table. You're starting to see like a jigsaw puzzle, but the pieces aren't all together yet, but you get a feeling that they're all on the table. So I think our community, our county, has a chance that is pretty unique, as you said. I don't know of other communities where so many people are pointed in the same direction. We just need to find a way to pull it all together a little bit more, develop the research around it. So we are really close. This is an important movement. You have the leaders of the field here, and really thank you very much for your time this evening.